Dear colleague, my name is Stephane Gaudry. I am an intensivist in Avicenne Hospital in Paris area. So I would like to thank the scientific committee of the ACKM for the invitation about this talk on the wait-and-see approach in renal replacement therapy. Is it good? This is the first talk on this topic. I have no conflict of interest regarding AKI or renal replacement therapy. In 2012, the KDIGO guidelines state that absolute indication to start renal replacement therapy are life-threatening complications, such as refractory severe hyperkalemia, refractory severe metabolic acidosis, and pulmonary edema resistant to diuretics. So what is the definition of the wait-and-see approach? This is postpone renal replacement therapy in critically ill patients with severe AKI who have no life-threatening complication. And what are the questions on this approach? Does it reduce the need for RRT? Does it impact survival of our patients in ICU? And does it modify the time to renal function recovery? The adequate study design to answer this difficult question is to compare strategy. In patients with AKI, you have to apply in a randomized controlled trial, two strategies, the early RRT strategy. In this strategy, all patients will receive RRT, and a delayed RRT strategy. In this strategy, some patients will receive RRT because they will reach pre-specified criteria, and some patients will not receive RRT because they will recover or because they will die before to reach this criteria. Three major randomized controlled trials have been published several years ago. The AKIKI trial, which was a multi-center randomized controlled trial including more than 600 patients. The ELAINE trial, a single-center randomized controlled trial including 231 patients in surgical ICU. And the IDEAL ICU trial, a multi-center randomized controlled trial, including almost 500 patients in mixed ICU patients. It was septic patients. So for the AKIKI trial, the first finding is that almost 50% of patients in the delayed group did not receive renal replacement therapy at the end of the follow-up. This is a very important difference between the two strategies. And as you can see, at the end of the study, there was no significant difference in terms of survival between the early and the delayed strategy. It was the same for the analysis of different subgroups, sepsis, severity scores, or a patient with ARDS. The modality, the timing of RRT did not impact mortality. In the IDEAL ICU trial, almost 40% of patients in the delayed strategy did not receive RRT, and the results on the survival is the same compared with AKIKI trial. The delayed and the early strategy, you can see on this Kaplan-Meier curve that the mortality is very similar. In the ELAINE trial, the delayed RRT strategy was associated with increased mortality after 90 days. However, in this trial, the inclusion criteria include fluid overload or worsening pulmonary edema. And as you can see, more than 70% of patients had fluid overload or worsening pulmonary edema in this trial. This led some experts like Norbert Lamer to state about ELAINE that ELAINE investigated the effect of delaying RRT in patients who really need it. Severe pulmonary edema is indeed universally recognized as an absolute indication for emergent RRT. Finally, this year, we published in The Lancet this systematic review and individual patient data meta-analysis of randomized controlled trial in the field. And we include in this meta-analysis 9 studies. We had 10 studies eligible, but we obtained the individual data from 9 randomized controlled trials, including ELAINE, AKIKI, IDEAL-ICU, among others. And finally, we had the data from 1,879 patients. And what are the risk of bias in this meta-analysis? You can see that the risk of bias is very low, and we did not find heterogeneity across the study. The primary outcome was all cause of mortality at day 28, and the result of the study is that there is no difference between the early and the delayed RRT strategy. You can see an hazard ratio at 1.01, and the second result is that 42% of patients in the delayed group never received RRT. This is a very important result. Among the secondary outcome, there was no significant difference, even for 90 days mortality or mechanical ventilation free day or vasopressor free days. The analysis of different subgroups show no difference in mortality between the two strategies. And what we can conclude to this with this systematic review and meta-analysis is that this is a very high level of evidence that the timing of RRT initiation does not affect survival in critically ill patients with severe AKI in the absence of urgent abdication for renal replacement therapy. This might reduce the use of RRT and thereby saving health resources. A few weeks ago, a START-AKI trial was published, and what we can say is that START-AKI confirmed that the wait-and-see approach should be the standard of care. This very important multi-center international randomized control trial include almost 3,000 patients, and I think that Sean Bagshaw will discuss the result of the study in the same session. So what are the results on the time to renal function recovery? Does the wait-and-see approach impact the time to renal function recovery? It's a very important question. In the AKIKI trial, we found that the delayed strategy was associated with more rapid renal function recovery when you look at the adequate urine output or when you look at the spontaneous creatinine decrease. So it was the emergence of a new concept, the concept of artificial kidney-induced kidney injury, the risk of early RRT. And this concept of artificial kidney-induced kidney injury was confirmed in the START-AKI trial, since in this very important trial, renal replacement therapy dependence after 90 days was higher in the early strategies, 10%, compared with the delayed strategy, 6%. Finally, I would like to alert you on a very dangerous methodological trap. We published this editorial in Critical Care a few months ago with Paul Palevsky. So what is this trap? When you perform a two-arm randomized control trial, you should compare the data according to group of randomization. This is very important thing. But some ones want to artificially dividing the delayed strategy into two so-called subgroups, patients who finally receive RRT and patients who did not receive renal replacement therapy. And after this artificial division, they wanted to compare the outcome between this so-called subgroup with the whole group of early RRT strategy. This comparison of these so-called subgroups is not interpretable for two reasons: indication bias. Patients who finally receive RRT in the delayed strategy were those whose status worsened. This is a time-varying confounding. And the immortal time bias, it is not possible to identify patients in the delayed group who will actually receive RT at the time of the inclusion, but only at the end of the follow-up. So to show you an example of this trap, you can see a post-hoc analysis of Akiki. If you consider that the early strategy is the reference with a hazard ratio at 1.0, and you look at the so-called subgroup of patients who receive RRT in the delayed group, you will wrongly conclude that delayed RRT is associated with increased mortality. But if you do the same with the so-called subgroup of patients who never receive RRT, you will wrongly conclude that never start RRT is a good thing to do. This is a nonsense. And after matching on severity score, of course, the difference disappears. So this kind of arguments are fallacious arguments. This is not good science to do this comparison, and all trialists, methodologists, and biostatisticians will confirm this. So to summarize my talk, the wait-and-see approach reduces the need for RRT. It's good for healthcare finance, probably less good for industry and for doctors who work for the industry. The wait-and-see approach does not impact survival. We have now a very high level of evidence to say that, and be careful of the methodological trap. And finally, the wait-and-see approach is associated with more rapid renal function recovery. This is a concept of artificial kidney-induced kidney injury, but we need more data on this. Finally, to conclude, this approach should become the standard of care.